This is Professor Tomas Rogula, founder of the IBC, and I am delighted to announce today we have another IBC University of Oxford Surgery webinar to be streamed via the IBC website www.ibcclub.org. The IBC University of Oxford webinar series is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars are to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford have allocated September 15 to 17, 2026 as the dates for the 7th IBC University of Oxford World Congress to be held at the Examination Schools, University of Oxford. For more information, go to the IBC website www.ibcclub.org. We would like to thank our global education partners for the 2026 IBC University of Oxford webinar series, which are Bariatric News, the International Obesity Society, the Upper Gastrointestinal Surgical Society, Laparoscopic Surge, Bariatric Channel, the Robotic Global Surgical Society, the Operating Room Global Foundation, and the Gulf Obesity Surgical Society. We would also like to thank our platinum sponsors Johnson & Johnson MedTech, Reach Surgical, XNY Medical. Gold sponsors Medtronic, MyConvey, ConMed, Carl Stores, Standard Bariatrics, Teleflex, USGI Medical, GI Windows, silver sponsor Azisor Medical, Arabian Co, bronze sponsor Intuitive. I would like to now ask the webinar chair to open the webinar.
Well, good morning, good afternoon, and good evening, everyone. Welcome to our webinar of the day, and we have a very exciting webinar. It's entitled Innovations and Future Directions of Magnetic Anastomosis Technology. I'm Christine Wren-Fielding. I'm a professor of surgery at NYU Grossman School of Medicine. I'm also the chief of the Division of Bariatric Surgery and the director of the NYU Langone Weight Management Program. But before we get started, I'm going to introduce my two co-chairs, Dr. and Professor Carlos Galvani. He's the Chief of Division of General Surgery at Louisiana State University Health Sciences Center and Medical Director of the Surgical Service Line at UMC New Orleans. He's a specialist in robotic, bariatric, and foregut surgery. My other co-chair is Dr. Eric Wilson. He's a professor and vice chair of surgery and division director, minimally invasive and elective general surgery at the University of Texas Medical School in Houston, Texas. And without further ado, I would like to have Dr. Galvani introduce our first speaker.
Yes, thank you, Christine. Thanks for the invitation. It is my distinct pleasure to introduce Dr. Professor Chris Thompson. Dr. Thompson is the director of Endoscopic, Brigham and Women's Hospital, Harvard University, Boston in the USA, professor of medicine at Harvard Medical School in Boston as well. So his talk is the Magnetic Anastomosis Scientific Foundation, Emerging Data and Implications for Healing and Nutrient Flow. Dr. Thompson?
Thank you very much. It's a pleasure to be here. Share my screen. All right. So, getting into the science of it to start. The agenda here for me will be to first focus on history of compression anastomosis, and then we'll get into the physics of magnets and how they work, and then we'll talk about magnetic anastomosis itself, the tissue effects, and healing. And you can see here, this is the very first compression anastomosis device that was ever made. It's the original one created by Francois Nicolas Denis in France. And he published his results a year later. And that's actually 200 years. That's a 200-year anniversary of compression anastomosis. So it's a real opportune time to talk about this. So He first reported those results in a canine model, and he basically would use these metal tubes, and it came with a pair of pliers, and you'd crimp the tissue onto the tubes, then slide the tubes together. And there were all sorts of issues with this. The materials they were using, weren't terribly sterile, so there was infection risk. And additionally, the body had a variable reaction to the crimping process. So, unfortunately, this didn't work out. But it was the first kind of conceptual demonstration that tissue compression could form an anastomosis, and it was successful in doing that. Then, following this was the next evolution was the Murphy button. This was in 1892. So this was the first one that had broad clinical adoption. And compression was generated by two brass springs. This has been used in a variety of different ways. It was used in gallbladders to intestine anastomoses, stomach to intestine, intestine to intestine, etc. And it really, I think the success was in large part due to that inner spring. It then faded due to complexity and other issues, and it took until the 1980s for the next wave of compression anastomosis to become available. This was the AKA-2 device, and this was of Russian-Ukrainian origin. Unfortunately, it did have limited commercial adoption. It wasn't really ever approved in the West, and that was probably why it faded. But it did have, a good deep clinical experience here. There was these non-resorbable rings, and what was different is that there was a lot of little springs on these pins. So they were trying to distribute the force better than with one large spring, which was seen with a Murphy button. And this was quite effective. This is one of the studies here, 442 consecutive patients. Bleeding incidence was 0.7%, stenosis incidence 0.5%, and leak rate was 2.4 to 5%. And this was quite striking because, this was in colonic anastomosis, and the stapled leak rates were as high as 20% in some series, the lower down you got at that time. So this was quite encouraging, and I think that, unfortunately, due to the fact it was in Russia and they really not got Western penetration, it didn't get broad adoption. Now, the NITI-CAR system came out subsequently. This was 2008, 2010. This was a registry study, and it's very similar. It still had those kind of separate pins with springs on them, and they studied over 1,000 patients in 16 different countries, and they performed basically left colectomies for the most part in this registry study. The leak rate was 3.2%. Median length of stay 6 days. This was pretty good for the time, and ring expulsion was 8 days, early as 6 days. There were some technical failures, but over 1,000 patients, this wasn't really that bad. Misfire in one patient, incomplete anastomosis in 3. The problem with this system really, and why it failed to get penetration, was the complexity of the workflows and the device. The nitinol had to be cooled in an ice bath, and it was a very tight fit, so it was hard to place. There were sizing issues, and it took a long time to use this, so it didn't get good clinical penetration. So one other thing here is, we would see from time to time with these compression devices that the device wouldn't migrate. It wouldn't come all the way through the tissue, or it might go too quickly. There were some issues with it. That was what would lead to the failure of passage or leaks. And this is really a good way to understand that, Hooke's law. So Hooke's law basically describes spring forces, and you have a constant, which is really the stiffness of the spring. Then you have how much the spring is either compressed or elongated. So the spring in a neutral position is not going to exert any force. But then when you constrain it, it's going to exert force. So the problem is, with time, as this is compressing tissue, it's getting more and more towards this neutral configuration, which means the forces change over time. So it's not a consistent amount of force being put on the tissue. So as this force is diminishing over time, this is what leads to failure of passage. The thing will dangle around in the anastomosis, eventually tear, and that can cause problems. So this is an issue with springs that really is something that's hard to overcome. And that's where magnets enter in, because they do not abide by Hooke's law and they don't have that problem. So magnetic fields basically form when electrons move in the same direction. So you can see in a wire, as they're moving through a wire, the magnetic field will encircle that wire, and they spin and they align together. And the basic concept is that electrons, when they spin, they create a magnetic field, and then paired electrons will always spin in opposite directions and cancel each other out. So in a solid substance, if you have a bunch of paired electrons, you're really not going to be able to create a magnetic field. However, when you have certain substances that have unpaired electrons, this is where the magic happens, because the unpaired electrons, they will start to spin together, all right, and they can align, and they can create magnetic domains. And this is what's important, okay? So you'll have a substance with unpaired electrons. They'll have multiple different kind of magnetic domains. They won't align necessarily, but within different segments, they will form kind of these parallel forces and magnetic domains. But then when you expose this magnetic substance to an external magnetic field, you can get these to align, all right? And this is where you can actually magnetize these substances. And the ones we're talking about obviously are iron, cobalt, and nickel. These are substances where you have these unpaired electrons that are magnetizable. And this is the basis, of which these magnetic surgical devices are created. So kind of going back to the early clinical experience with magnets, the first human cases that were described were in 1980. And they had these two rings that were created and coated in erlate. It was a polyester substance, and they would place these in the patient, and they did low anterior resections and sigmoid resections, 21 resections in total. And with this very early clinical experience, they noticed dehiscence in 3, a hematoma in 1, and 1 death. 18 did heal. So, again, proof of concept, but the complication rates were a little too high for that to be commercialized. The next device was a combination of a magnet and a stent, and this was in 2005. And the Cook company was involved in this as well. And they basically were trying to do gastric bypass procedures for the treatment of pancreatic and biliary malignancies causing malignant gastric outlet obstruction. And they studied 15 patients. They had this yo-yo stent design that would be placed sort of like the modern-day lumen-opposing metal stents after the magnets would pass to hold it open. So the problem here is when you're working from above in the foregut, the size of the magnet you can use is limited by the upper esophageal sphincter diameter. So you really have to, you have some size constraints there. And the solution to that for this group using solid magnets was basically to use this yo-yo stent and to keep that open and maintain patency. So the technical success of this procedure was about 88%, and that's being able to force those magnets through the area of obstruction endoscopically. However, there were some complications, a 30% complication rate, mostly related to the stents, actually. I think that the magnets did a pretty decent job, and it was either distal migration or obstruction due to the stent migration. But because of the need to rely on the stent, this also failed. That's what it looks like. And finally, Anastomosis, that was the most recent version of these kind of solid magnets. This is, again, they're using these Harrison ring magnets. They have some geometric creasing to help them fit together and not slide on each other. And they studied this in 5 patients. It's open surgery now. They had complex open urinary reconstruction procedures, and they were trying to basically restore small bowel continuity. And the magnets actually did form successful anastomoses in these patients, and they passed. So kind of a little success story at the end of that with solid magnets. But I think that, across that time with those early human studies, and then it basically inspired kind of back to the drawing board a lot of animal work. And I think this is where the science comes in, right? So you have tissue necrosis in the middle with your compression zone, and then you have tissue remodeling around that. And the best kind of way to think about this is in the context of traditional wound healing stages, right? So you have hemostasis initially with coagulation, and you have platelet activation. So we typically see this as a spike very early on with a clot formation and you start getting a provisional matrix there. Then you have the neutrophils that are recruited in, and neutrophils, of course, are going to try to control the bacterial contamination and do debris clearance. Then you have your monocytes and macrophages, which come in, and they are involved in immune signaling and start to transition to repair. And then you get your proliferative phase with fibroblast activation, you get angiogenesis, and some matrix deposition, and then eventually maturation and remodeling, which is largely dependent on myofibroblasts, and you get your collagen remodeling there. So this is how we think of wound healing. And compression anastomosis does change this, right? And in part, it's because of this very early collagen seal formation, which you're not getting. You're not getting this necessarily with staplers either because of the penetrations you get with the staplers or with suturing, right? But this is truly compression without breaking any tissue planes. So initially you have this cellular crush injury, which compresses basically the interface, and you're pushing your serosa, et cetera. Then you have lateral fluid extrusion. So all the fluid is going to try to escape into the interstitial spaces as it's being forced out by this compressive force. And it will eventually be taken up by capillaries and lymphatics. The collagen and extracellular matrix proteins then remain very concentrated in this area because it can't escape, okay? So they become more and more compressed. With that mechanical compression, the fibers start to align in a parallel configuration. And this closeness and this pressure actually causes certain intermolecular interactions. So you'll have electrostatic charge interactors, hydrogen bonding, matrix protein interactions, and then it basically fuses together. And what this does is it creates a collagen seal that is waterproof, and it's a high resistance barrier. So we think this is in large part what really affects the healing principles that we see with compression and anastomosis. And this is similar to the prior wound healing slide I showed, where you have your inflammation portion, proliferation, and then eventually remodeling. We think this greatly shortens this compression mechanism in the collagen seal, shortens this process. So you can get into remodeling much earlier at around 2 weeks rather than 25 days. So there are several animal studies that have looked at the kind of tissue healing following compression. This is one from our group. And basically you can see here the magnets, the staples, and the sutures, and then you can compare these to native tissue as well. And first we have tissue thickness. And with magnets, the tissue thickness, it remains very thin. So it's very organized and orderly. So the healing tissue plane remains very thin, unlike with staples, which is very thick, as well as with sutures. The reduced luminal circumference is also non-existent with magnets. There's no reduction in luminal circumference, where with staples and sutures, you see about a 22% reduction, again, due to that disorganized healing. And then you can also see the adhesion score is considerably better with magnets as well, 1.1 versus 1.3 with sutures and 2.5 with staples. Further, this is a leak test, and this is pretty consistent across all studies. The pressure at which you are able to induce leaking or burst of the diffusion line is much higher with magnets. It's twofold higher than with staples, and very similar to suturing. And of course, if you look at this just on gross, you can actually see the granulation adhesions, which are of course far less in a magnetic anastomosis. You see a lot of times microabscesses and signs of infection along a stapled anastomosis, which again you don't see typically with magnetic anastomosis. So this is another study from our group, basically looking at early histology, and right away on day 1 in the initial histopathology, you can see compression, and the collagen fibers between the segments are really aligning already. So this is, again, something you're not going to see as much with staples. So it's very early on. And day 1 to 3, then you start seeing your mucosal bridging, and the early seal is really taking effect here. It's very prominent. Your collagen is going to be staining blue and whatnot, and you have fibroblasts beginning to form a matrix deposition. You get necrosis and sloughing at days 3 to 10, where you can see that compression zone has really been walled off very nicely and starts to slough off. And on the outside, you can start to see neovascularization of the tissue, and you're already getting into remodeling here. And that's something that's very unusual. So what about, what genes are being expressed? This is a very interesting study from a group in China, and they did it. It's in Sprague-Dawley rats. They studied 20 rats. 10 of them had a magnetic compression anastomosis, and 10 of them had a hand-sewn anastomosis. And they did the typical functional and mechanical assessments, and they found that survival was higher in the magnet group. Complications were lower in the magnet group, 0 versus 3. The hand-sewn group had a couple of leaks in a stricture, and burst pressures were higher in the magnet group as opposed to the hand-sutured group as well, 174 versus 161 millimeters of mercury. So this is what we see in all the studies, all the different animal studies. But the histological results were also very similar to what we've been seeing in these other studies as well, with reduced scar and collagen disruption and just more organized healing. But what was very interesting about this was the transcriptomic and molecular analysis. So they did RNA sequencing to basically figure out what genes were active in the area of the anastomosis. So they harvested the tissue, and then they did the transcriptomic analysis on the tissue itself, and they were able to actually find a few different things. So one thing was that certain genes were being expressed differently in the magnetic anastomosis versus the hand-sewn anastomosis. So there's differentially expressed genes, and there were 209 of these. 124 were upregulated in the magnetic anastomosis, and 85 were downregulated. I think that this volcano plot is probably most instructive, where you can see on the right the upregulated genes, and on the left the downregulated ones. And the ones that are upregulated are the neutrophil chemoattractants, which would help obviously with bacterial control and cleanup. And so you're getting a much better neutrophil response, as well as the matrix metalloproteins, and that's very very helpful for tissue remodeling. And it's also important in early matrix formation and healing. So some interesting studies there. Now, we know that magnets can form a good collagen seal. We know that the healing process is expedited in these animal models. And this is good, but we've also learned some lessons from the solid magnets themselves. Certainly they have several beneficial effects. Gapless healing margin, very good. Effective against different tissue thicknesses. This is something that's good as well that springs were not as good at. So there's different things we're seeing in these studies, but the limitations really are that for procedures where you're working in the foregut, you're limited to very small magnets, which is not ideal, obviously. So that is one issue. Additionally, if you want to place these laparoscopically, it is limiting the size of the magnet you can use. And that's important because we know that to maintain a large anastomosis, durably, it has to be a certain size. And generally, we think it's around 2 centimeters. But very small fistulas will close on their own. They won't be effective. So we do need larger anastomoses for them to remain intact. Additionally, immediate patency has been an issue with solid magnets. That's something we do worry about. And then ease of use has been an issue as well. So that's where we started our project back in 2009, trying to create self-forming magnets that would have a window in the center of them, and also be able to go through a very small catheter, and then form a larger structure to create durable anastomoses. So we started in 2009, and then it progressed sequentially until we have kind of our octagon type magnets now. And this was our first human series. This was our pilot series in humans, and we did this with 2 endoscopes. So initially it was meant to be a kind of a fully endoscopic procedure. The first magnet was placed just beyond the ligament of Treitz, and about 30 centimeters beyond, and the bottom magnet was placed up above the ileocecal valve. They then forced together endoscopically under fluoroscopic guidance. And that was not easy to do, for sure. We did have laparoscopic assistance during this. They would snap together, and then we followed the patients. And so what we were doing here was a side-to-side anastomosis. It wasn't, along the lines of a jejunal-ileal bypass where we had a long blind limb. So this created a treatment path so that food could basically bypass a large segment of the small bowel and just drop into the distal ileum. When the goal was to trigger hindgut mechanisms. You wanted to spike GLP-1, et cetera. And then we wanted to preserve that native path rather than creating a long blind limb to avoid all the problems with oxalate and leaky gut, and we saw the true jejunal ileal bypasses. And so this is working on hindgut mechanisms. And you can see here in this first in-human study, this was what the first kind of human magnetic anastomosis looked like. It was very large, it remained patent, and it healed very nicely. So we were very happy to see that. 3-year data on this cohort. So we studied 10 patients, 3 had prediabetes, 4 had diabetes. And we saw the ones with diabetes, the A1C dropped from 7.8 down to 6, prediabetes 6.1 to 5.2. So clearly improvements there, and they had about a 14% total weight loss. So very good kind of early results there. And since that time, we pivoted to these surgical procedures and surgical endoscopic hybrid procedures. I think you can see Professor Galvo there deploying that. And basically, you'll place one endoscopically, you'll place one surgically. You're going to see more of this later. And then you're going to snap them together. And that really has shortened our procedure times and been very helpful. And you can see here that we have 11 clinical studies that have been ongoing. I think we're up to 12 now. And the beauty of this is immediate patency. And I think future speakers are going to talk more about our little delivery system and different procedures that we've been working on. So this is one study that we did recently publish in Gut, again, going back to mechanisms that was part of the talk title here. And just from this kind of this magnetic anastomosis, where we're just doing a magnetic anastomosis, no gastric part of the procedure, just kind of doing a duodenal ileal diversion, we found some striking results, in particular true spikes in GLP-1, spikes in PYY, and these did predict greater reduction in HbA1c at 12 months. So it does potentially change the paradigm where you might want to do a small bowel anastomosis first, see how the patient does, and then decide whether or not to do a gastric procedure. So kind of the opposite of how the sleeve gastrectomy was originally conceived, as you can get a very early signal at 1 month as to how they'll do long term, both from an HbA1c standpoint, but also a weight loss standpoint. Other devices on the horizon, we're going back to another fully endoscopic version of this, where you can actually assemble your magnet on your endoscope and then using electric cautery, access another part of the bowel, and place another magnet distally, very similar to how lumen-opposing metal stents are being used currently. And so this is one of the newer iterations of that system that are now getting into preclinical studies. And of course, different ways of steering these as well. There's other companies working on this too. This is another system where a magnet is swallowed. It's sort of a bar magnet. And then you come in and you kind of grab this with a laparoscopic device, position it, and then place another one where you want to in the stomach to create an anastomosis. And they're trying to make up for these size constraints by making the magnet longer to try to create a durably patent fistula. So in conclusion, magnetic compression anastomosis appears to have several advantages over traditional stapled anastomoses and stenting. Several platforms are under development and will be clinically available soon. And data is early. Certainly more rigorous trials are needed in some regards, but I think that we've shown that these are safe and give durable results, and we're going to hopefully start to see good clinical adoption soon. Thank you very much.
Great. Thank you so much, Chris. It's fascinating and so much excitement around this. Next, I want to have Dr. Wilson introduce our next speaker.
Thanks, Chris. As always, it's an honor to be here. I'm going to introduce Dr. Andre Teixeira, professor of surgery at Orlando Health. He's director of bariatric surgery there and a high volume robotic minimally invasive bariatric surgeon, bariatric endoscopist. And he's going to talk about magnets in the small bowel applications and the workflow with those procedures. Thanks for being here, Andre.
So my job is to talk about magnetic small bowel anastomosis, more specific with the GI window flows technology. And let's see if I can deliver this talk. So I'm just going to minimize something here real quick. Okay, so the vulnerabilities of mechanical fixation of stapling, right? So a couple of things. One is clinical risk, leak, bleeding, stricture, obstruction. As we know, we do create a lead fixating point, which can create intussusception in the future, as we've seen multiple times with small bowel anastomosis, tissue trauma, right, from overtension, and variability in tissue compression depends what height you use, what staple cartridge you use, the thickness of the bowel. So there's always a reaction to it, depends on how the tissue is going to react to it in terms of creating more of a fibrosis or not, and also a foreign body response. So the key takeaway from here is the promise of magnetic compression is not only operative speed, right? Because speed, it's important, but it's not the biggest thing to me. The biggest value to me is the sterilization of the tissue capture and healing, as Chris Thompson already talked about the biology of it, so I'm not going to get into it. But to me, the standardization of the technique and allow us to have a anastomosis that looks like the patient was born with a week later to 30 days later. So continue. The evolution toward, right? The phase one, we had sewn, and then the stapling perspective. Then we had compression devices. That was, Chris already alluded to it. And now for the more current, the cell-formed magnets, which is more of a controlling compression, more of a natural tissue remodeling, zero permanent foreign body, as we've seen in some many videos and some presentations. We allowed to redefine the tissue apposition, right, serosa to serosa, instead of more of a mechanical staple that we cut into tissue through all the layers, kind of forcing them together, independent on their thickness, to a more of a biological healing process with magnets, which to me creates more of a seal compression interface, more so than just a forcing and cutting, putting things together with metal clips for that matter. The other thing is more of an engineer control compression, right? With the Flexagon, you have the cell-formed magnets composed of nickel and titanium, right? Which deliver a equally distributed tension and compression all the way around, together with the autolock system that allows an immediate connection with flow with it, which is a fantastic way to create this immediate anastomosis, not just a delay pattern. The three phases, just to make things simpler, Chris Thompson did a fantastic job, but he's way smarter than I am. So think figures work very well for me and very easier things here to understand. One thing is compression, right? As we know, compression is going to create some ischemia, which magnets lie across the bowel segments, attracting forces, creating more of a control, central ischemic and necrosis while securing the outer edge. That's number one. Number two, you're going to have a remodeling with a cascade of reactions, serosa to serosa position, which allows for the body to heal the surrounding compressing ring and causing reepithelialization into more mature seamless anastomosis. And subsequently, you're going to have the expulsion after the expulsion, the autolock already happened, right? And then you have the expulsion magnets, which can vary between 3 weeks to 6 weeks, which it goes right through it. to you. And then when you look at it, you have the opportunity to do any endoscopy or any look at the imaging, you're going to be able to see that it looks like the anastomosis the patient was born with it, without any inflammation, no reaction whatsoever. We saw with the latency, the biggest constraint that we had on the old technologies were, this is a classic magnetic compression, but there was now a way to connect both sides to create the autoflow or flow. Well, that was fixed brilliantly with the autolock breakthrough, right? That is a way to preserve the anerotomy, so you don't make the anerotomies longer or larger as we deploy the magnets. And the same token, we can use that to create our autoflow or your connections. The GI windows, when you look at the technology, there are two ways. I said the track ACM, that's how kind of like the sutureless end-to-end anastomosis by magnetic compression. So if you look at like a ileostomy reversal type of thing, histologic control, propensity match design, and then you have the flows, right, which is more of a functional looming opening with a self-forming magnetic anastomosis, laparoscopic small bowel anastomosis, ilio to ilio, jejunum to jejunum, duodenum to ilio, and so forth. More of a flexagon with the autolock technology. It can be done robotically, as we've shown. You just have to keep some of your arms farther apart, but with vessel sealer, you're able to manipulate very well without any difficulties. When you look for the FDA clearance, the indications are side to side, jejunum, jejunum, ilio. They do ilio anastomosis. We have to provide more cases to be able to get that FDA clearance for that portion, which we're already working on it. It's minimally invasive laparoscopic surgery, adult patients greater 21. That was the biggest thing. And there's some clarification. This is not a weight loss procedure, right? And also the safety warning, which was not MRI compatible. So we still looking at that and studies in that manner. The validation dashboard, if you look at it, it's 84 evaluated patients, including US, Chile, and India at the time, 100% fluid flow, completely open implantation, zero anastomotic bleeding, zero intervention in these cases. The average was about 42 to plus or minus 5 days of baseline, and then less than 20 days exposure time in animal evaluation, right? So again, very good outcome on the human database and also the porcine database. This is a video of us that we did a couple of weeks ago of our bypass using the Omega technique. There are different ways to do it. I tend to like to keep my Omega intact while I use my to do my JJ, because it gives me more of a support area on one of the limbs, right, on the biliary limb. So, but it's pretty straightforward. We come in and we are going to create a more of an anerotomy. On the small anerotomy, it doesn't have to be big, very small. And on both sides, same way. I tend to, that's the way to do it too. More of an anti-mesenteric, and then subsequently we deploy the autolock. So if you think about it like a stapler gun, is the same way with a cartridge, where you put the Medtronic stapler. So you put a cartridge, which is cartridge A, which you're gonna have the autolock first, and then subsequently the magnet, all deployed in one cartridge in 2 steps. And then you're gonna do the same thing with the B portion, which is gonna be the distal portion, or if you want to vice versa. All right, so here you come in, and the trick part here, just give it some support so you can see a little bit of the autolock, and then it deploys on both sides, and then again you redirect the gun, and then deploy the magnet distally, and then you pull it back to you. And then what I like to do is use my arms to support, especially more with my vessel sealer, just to reposition the magnet within the autolock. I like to see that magnet really centered, with the autolock really centered next to it. So that magnet is ready to go. Then I'm going to deploy the second one. As you're going to see when it comes in time, When I lift the magnets to join with the other magnet or the other limb, that's one of the reasons why I like to keep it more, all of that limb intact and not separated. But again, dealer's choices, right? It's whatever works for you. For me, it tends to work very well when I deploy my magnets. Again, look at that. So I can use it and keep that. My vessel seal is almost like I fold it underneath. You can see if I take some of those sutures, I want to make sure it's completely centered. So once that's done, I'm going to go ahead and take my magnet and kind of come next to me. Just trying to find the right way of folding it and adjusting my, they're changing my arms. And then sometimes in some cases, we like to, if there's not enough reach, if I feel like it's not folding down, then I'll transect it, right? Just to bring it down. So there's two ways you can do this. Just how the magnet is positioning, in my personal opinion. So again, once you're able to free it, you got the wrong way here, then I adjust it, boom, done. Anastomosis is done. And then I like to keep a little longer. I cut those strings, and then I like to look all the way around as I'm seeing here. Make sure that I don't see any exposed orlocks, right? Even if there is an exposed orlock, you just have to give it time. Once the time's given, that's perfect. As you see, the anastomosis is completely done, and you can see the weight of the magnets brings down that Achilles heel of the omega loop technique, which is the anastomosis tends to ride higher, which can cause an obstruction. By the magnet weight bringing down, it fixes that problem. Again, the technical nuances and operational realities are basically patient selection and bowel selection. Avoid excess bowel wall thickness. People there are on steroids or have inflammatory bowel diseases or have issues ischemic bowel, mesenteric twists, of course, right? Procedural precision requires controlled access and neurotomy. Again, a small neurotomy in a well-deployed orlock can make your life very, very easy. Complete device setting and precise mating alignment are mandatory. Is the easiest way to put it together. If you don't like it, the way it looks, take them apart right away. Once you take them apart, you start again, adjust yourself, and put it back on. Okay? Again, in post-market reality, strict MRI restrictions, right? So again, keep that in mind. We give cards to the patient. And sometimes, if we have questions, we might get an X-ray or not on those patients post-op or even 30 days later. Right now, that's not part of our protocol yet. Just for comparison, magnet versus mechanical. One fixation point, right, is a fixation thing. Magnet is a remodeling, compression. Lumipatices immediate via cutter line. The ones via an orlock access system. Tissue impact, more of a fixed compression technique variability based on which cartridge you use, what color you use, and what length. Versus an adaptive remodeling, it creates a standardized compression and a standardized anastomosis, which is very good for bariatrics. Foreign body, permanent staple line remains 100% natural passage, zero permanent material, zero fixation point that will create a possibility of creating intussusception in the near future. Again, just figure out your way to do it. It's very important to look at some cases, proctor, and so forth. The same way we learn some techniques, be the same way we're going to learn this. Select alignment, the access control of the orlock, deliver the first device, make sure you like it, and then repeat the same thing over the second device. And then once you make them, you have to confirm. Do not confirm. Look at posteriorly, look around, make sure you don't see any visible orlock device. And just give it, if you see it, give it time. Again, same thing, didactic training, interior case selections, you do a dry lab, animal cadaver lab, proctor first cases, and then retro capture and quality dashboard. You do it your own self, right? So we were able to go you through this process within a day and a half tops to get this ready for you. quality metrics tracker to meet operative time deployment, conversion to stable, leak bleeding rates, imaging use, device passage time, late stricture. I think once you keep that and you convince yourself, we are probably going to reach about 50 cases by the next couple of weeks. So then we're going to look at our first 50 initial cases. New anastomotic language, self-alignment, immediate flow, control biology, zero permanent foreign material. The future of anastomosis is not sharper staplers or faster suturing. It is a control biology, a connection that heals itself while the devices disappear. This is just a dashboard, which I can share this with anyone that kind of puts everything that I talk about it in a small graph. And thank you very much for the opportunity. And I'm available anytime, and I can share my talk anytime you guys want. Thank you very much for the opportunity.
Thank you very much, Andre. It was terrific. And again, due to our time constraints, we're going to hold off on any questions. And if we have time at the end, we may have a discussion or ask some of the speakers some questions. But we're going to continue with our agenda. Our next speaker, unfortunately, cannot be here in person because of some flight delays. But Dr. Mohit Bhandari is quite kind enough to send his talk of video. But Dr. Bhandari is a founder, director, and chief surgeon of the Mohak Bariatrics and Robotic Surgery Center. He's professor of surgery, gastroenterology, and he is the vice chair at Sri Aurobindo Medical College in Indore, India. He's a pro-chancellor of the university, and he's going to be talking about gastric applications of magnets and clinical experience.
So, good evening, everybody from India. At the outset, I would like to thank Professor Harris Khwaja for inviting me to this great meeting in which we are going to discuss something which I've been working on since last 1.5 years. And we are extremely proud to be one of the largest volume centers of gastric applications of magnets. And it's an honor to share our clinical experience here. So bring greetings from India and IRCAD India. These are my disclosures, our case mix. Now probably considering the GLP-1 drugs, where the number of bariatric procedures are decreasing all across the world, they are increasing here in India because of favorable insurance towards the surgeries. And hopefully we will cross 2,500 bariatric procedures this year, which has never happened before when the GLP-1s weren't there. Because of them, we are growing. This is my mentor, my teacher, Manuel Galvao Neto. He heads the bariatric endoscopy department and also joined by Professor David Cummings as the head of obesity medicine here at our center. This is a special picture with Jack Marescao, Manuel, me, my brother, and my father on the installation ceremony of IRCAD India. Whenever you get a chance, do visit us here. We have a beautiful robotic lab now, almost 5 different robotic systems, most companies supporting us. Now, why do we need magnetic compression? We already had circular anastomosis. We had, linear cutter staplers. We could do it hand-sewn. But what we realized that tissue ischemia, bleeding, marginal ulcerations, and post-operative strictures remain a significant cause of morbidity. And so magnetic compression technology in the stomach introduces a different concept in which tissue remodeling occurs gradually and physiologically, potentially reducing tissue trauma while simplifying this reconstructive surgery. That's what we believe in. And the concept of magnetic compression anastomosis, I think all of us know that it is based on controlled attraction of 2 very strong magnets, which are self-forming circular magnets. And this sustained compression across the tissue interface leads to localized ischemia and necrosis while preserving the peripheral tissue healing. And over the time, it creates a neo-anastomosis without need of sutures or staplers. And it creates a very smooth, gradually formed connection that differs fundamentally from abrupt mechanical stapling. So the bariatric anastomosis has evolved from hand-sewn to linear cutter to circular, and now has turned into the magnetic compression. This is not new. This was explored many years ago. It was applied to esophageal, biliary, and intestinal anastomosis before, but I think the sleek design and the conceptualization, the data has just started to arrive. So what is the magnetic placement technique? The magnets are introduced either laparoscopically or endoscopically based on the anatomical site and surgical axis. Accurate placement is confirmed intraoperatively. Once the magnets are aligned, tissue apposition is achieved. And the anastomosis typically takes 7 to 15 days, where the autolog device, which holds the magnet, passes in 48 hours and the magnet passes in around 15 to 20 days, average around 18 days, and the anastomosis is formed. So this is compression ischemia, tissue remodeling, controlled healing with passage of magnets spontaneously. Now, we are one of those centers which have not devised a new procedure. Like many other magnet companies, there is a completely new procedure to be done where you have to swallow a magnet and then a loop duodenal has to be done. Whereas with us here working with GI windows, somehow we were lucky that we have been able to do the regular procedures what insurance approves, like one anastomosis gastric bypass, a conventional Roux-en-Y gastric bypass, a SADI-S and a SASI by both laparoscopic and endoscopic techniques. So in our country, the insurance would reimburse these surgeries. So now you see this is a very typical one anastomosis gastric bypass. You start to staple and make a long tube like we have always done. So this is a very, very long tube. We usually make 18 to 20 centimeters long tube. We start to count from the IC junction around 300 centimeters, and then we make a small enterotomy. You can use a hook or you can use a Maryland. This is a device by GI Windows. Device will first fire autolock, which is just like a silicone material to keep the magnets in place, and then it will fire the magnet. So you can see the magnet coming on the surface of the bowel. That's a circular self-forming magnet. And this thread is used to push the magnet and, pull the magnet towards the surface of the bowel. Again, the same thing, make a small gastrotomy, fire the autolock device, fire the magnet, pull the magnet out, and then you bring the leg end of both the magnets together and then automatically they align. Believe me, the way you see it is as simple as the way you see it here in the video. Now we do the endoscopy. So you see this looks beautiful. On endoscopy, again, this is the staple line. You enter here, this is the anastomosis. So the autolock and the magnet on the gastric side is seen. And if you can see very carefully, you can see the autolock and the magnet on the bowel side. And the air gets filled in both afferent and the efferent loop. You can suck the air and then you can come out with an endoscope. So this is a beautiful concept. Again, SADI-S, nothing special. You divide the sleeve just like you do, divide the duodenum, and this is the first part of the duodenum where you introduce the autolock device. And then once the autolock device is there, you can introduce the magnet. It's a very narrow delivery because very small duodenum is there. Bring it to the surface. Again, count around 350 centimeters or 300 centimeters from the IC, make a enterotomy in the bowel, put the autolock device and put the magnet. And then you can see that once you have done that, again, the magnet will be introduced after deploying the autolock device. And you can see once done, we can pull the magnet onto the surface of the small bowel very easily through a thread, which is already given with the magnet, and then just bring the two of them together. And the anastomosis is being made. So I think this is the beauty of this particular company, GI Windows, that you don't need to alter the procedure and you just need to do what you're doing. Again, see on endoscopy, beautiful images here. This is the pylorus. You go past pylorus, you see the magnet there, and then you see the magnet and the autolock device on the other end. And this is a beautiful anastomosis. So what I'm thinking now is that we are able to get insurance reimbursed for magnets because we are doing the regular procedures, the one anastomosis and Roux-en-Y in India. And so we can also use robotics and combine these with the magnets. So you can see that I'm not a big fan of CMR robotic system, but this is the one done with the CMR. Again, you see, this is a long tube which we made. Make an enterotomy into the tube, fire the autolock device, then fire the magnet, and then bring the magnet to the surface. And then again, this is by endoscopic method. You can bring the magnet inside by endoscopic application, put it in any part of the stomach, and in this case, a OAGB, which is the end of the tube. And then once you have deployed the magnet, you can go and apply some suction at the back of the magnet and bring in. So you can see that this is the magnet, and this is the autolock device. And then you can bring both of them close to each other, just like that. And you can see that the anastomosis is made. So this is done by robotic. You can again, you can see that these all, they look very beautiful. On the endoscopy, this is a SASI endoscopy done 6 months later. These anastomosis looks as if they've been made, originally not with the surgery. I can go and show you a lot of these videos, and I think they are the proof of the concept, and also would show us how these things, they look 6 months, 1 year later, without marginal ulcers, without strictures and stenosis, and you can see how beautiful this anastomosis looks. So I think now we are at a stage where we can combine endoscopic sleeve gastroplasty with a magnetic anastomosis. And I think that makes sense because we already know that a magnetic compression based one anastomosis with ESG can be something where you're not able to, give a very large restriction, but you are able to give good malabsorption. So I think that would be a very effective procedure in future. And the magnet placement with ESG is simple. With Manuel here at our center, you can see this is the device. We have done like 15 to 20 procedures, and you can see this looks really beautiful. So here is what Manuel did. I am just a very small part of this procedure, just making a small enterotomy and putting the magnet in the bowel. But this is the major part is being done by Manuel, where he brings in the magnet into the stomach, deploys it at the greater curvature of the stomach, around 4 centimeters above the pylorus. And once he would deploy it, you can see that the magnet is now coming inside. And once he deploys it correctly, we can go and assess the position where it needs to be deployed. Here, the greater curvature of the stomach, bring the bowel close to it, and the anastomosis is being made. This anastomosis is not patent immediately, but it will get patent. It's a transit bipartition, so we need not bother. Usually we make an enterotomy, gastrotomy where the anastomosis become patent immediately, but here you can see it will get patent within 15 days. But then we bring a double lumen scope and do the endoscopic sleeve gastroplasty. So this is beautiful. I think this procedure probably will form the future of bariatric endoscopy, where this anastomosis here, 300 centimeters from the IC, and this endoscopic sleeve gastroplasty beautifully done here. This will constitute the kind of metabolic procedure we are looking forward to. And I think endoscopic sleeve with magnetic one anastomosis transit bipartition is going to be the new procedure. Again, the magnet pass between anytime 17 to 21 days. Anastomosis is formed 10 to 14 days, and we need to put these patients on liquid diets for 3 weeks. I usually give them a pure liquid diet. We have some very good results. You can see 99 gastric procedures, 33 ROI, 9 SADS, 42 one anastomosis gastric bypass, 5 SASI, 6 ESGs, and 4 sleeve loop bipartition snaps. You can see average placement time. So 3.2 minutes, 3.2 minutes. Average is 3 minutes. Total procedure time is 50, 30, 55 minutes. Absolutely minimal blood loss, and hospital stay is around 2 days. Again, the same thing, the weight loss. That should not be different than the conventional stapling technique. It resembles almost the same. It's the same 30% total weight loss at 12 months, 35 with SADS, 33 with OAGBs. So I think that's good. And we are very, very happy with these results. There was no adverse event, or there was no complication, no mortality. We had, at 60 days, 1 marginal ulcer and some continuous vomiting and 1 constipation with RYGB-JJ, but rest all, there was nothing. You can see this is how they can be looked on the X-ray. Here you can see the magnets. In RYGB, you can look at here. In SG, they are here. In SADS, they are here close to the duodenum. So the location of magnet in different procedures. This is how they look when they come out in the feces. This slide shows the average magnet out time. It's around 18 days, I would say. This is 20, 17 for OAGB, 18, but average is 18. I have huge experience with these. Now we have shifted to colon, and we will be soon working with the megagon. So the ileocolic anastomosis we are doing. Unfortunately, my part of the lecture is just gastric, but I'm excited. We crossed 50 colonic procedures already, and I think that's going to be there. We'll present more data. Hopefully, Harris calls us for a colon meeting also. So this is the conclusion that MCA offers safe, standardized, minimally traumatic alternative to conventional anastomosis and bariatric surgery. our experience is now almost 100 plus cases. I think we have the largest number of experience with these magnets. I have given to known by GI Windows, and I think this is going to be the future. So thank you very much for this opportunity.
Thank you. Our next speaker is going to be Dr. Antonio Caicedo. Dr. Caicedo is Chief of Colon and Rectal Surgery at Orlando Health and Medical Director of Orlando Health Colon and Rectal Institute. He's an Associate Professor of Surgery, University of Central Florida and Florida State University in the USA. His talk is going to be advancing anastomotic techniques in colorectal surgery, initial experience, and magnetic compression. Dr. Caicedo.
Thank you very much for the invitation and the opportunity to speak about this. I'm going to try to not be very redundant. Many things have been explained, everything about the history of anastomosis was talked. Some of the things that I include here is when I'm usually talking to an audience of colorectal surgeons. So we go all over the history and the staplers and how things advance. Dr. Thompson already made a very detailed and beautiful explanation of all the previous devices for compression anastomosis and how they work. In colorectal surgery, well, in every gastrointestinal procedure, having a leak is a significant problem. But in colorectal surgery is the devil. To have any kind of anastomosis, we know the dry way of fecal matter, 60% is pure bacteria. So anything that happens when it leaks is catastrophic for these patients. And the more we moved an anastomosis towards the left, the worse the consequences are. And this picture just show everything that has been done to try to minimize or eliminate the anastomotic leak, which is something that at this point still has not been achieved. We know that the technology that we use currently, and that has been demonstrated by the previous speakers, either if it is staples or if it is sutures, there is perforation, there is microperforation of the tissue. And these are pictures from previous studies published, and those microperforations really are going to lead to microabscesses. I think this explains in colorectal surgery why sometimes you create an anastomosis that is technically perfect. You're super satisfied with things, and then the patient leaks, and you cannot explain as to why. There is multiple potential theories, the microbiome, the nutritional status, the immune system, many, many things, but still there is not really a good explanation. To aggravate the problem is we always have to pick what type of stapler we're going to use. And the evidence demonstrates that colorectal surgeons and general surgeons were really bad at selecting what is the real height of the staples that we need to use. We're not really good at picking and selecting what is going to be the right type of device. So it's very variable, and there is no any kind of a dynamic progression as the tissue thickness varies depending on the status of the situation. In addition, we have, if you see this one's 3 rows at the top are supposed to be what is acceptable for the staples. We don't know that. We create a colorectal anastomosis, we create an ileocolonic anastomosis. We have no way to really know for sure. We can only just assume that they deploy properly. And if we do a colorectal or a very low anastomosis and we see the staples in like shape of the 2 rows at the bottom, there is very little things that we can do. The technology for staples really, has progressed and has advanced. This is what we have more recently, the 3D, as it is called by the manufacturing company, in which they create this kind of configuration that has not a direct opposition of the legs of the staples, but still, the way I believe the technology for staplers has progressed is summarized in this. Despite of all the years, despite of all technology, nothing has really changed substantially, and still the perforation of the tissue continues to be a problem. From 2 rows to 3 rows, there is essentially no difference. In fact, I believe is could be even worse because you add more microperforations to the tissue. Challenge in colorectal surgery is with the previous methods for compression device is we cannot afford an obstruction, even though if it is temporary. In bariatric surgery, patients are somehow diverted in a different way. We cannot afford that in colorectal surgery. And I believe this is exactly what I was talking about. And I believe this is the key difference with the device from GI Windows, that there is immediate patency with this autolock. And I believe this is why it is so interesting and appealing to colorectal surgeons, and I believe general surgeons in general. This has been already described. It's a self-forming magnet made of rare metals and joined with nitinol. It acquires its shapes when it is deployed. So there is the integration with the autolock, the magnet itself, and then it has to be centered. This is a nice demonstration for what happens in a right hemicolectomy. The segment has been removed. Subsequently, there is the colotomy that is created with the same device. The ring or autolock is deployed, then same device is going to deploy the magnet that is going to form in that octagon form. It has a little bit of a learning curve to be able to manipulate the magnet, and this can be done either lab or robotically, as demonstrated by the previous speakers. And as easy as that, once you deploy that, then the magnets are going to be aligned. We bring kind of like the heels of the magnets together and we align them. This is part of the first cases performed in humans. This was in India, actually, at Dr. Bandari's facility. I had the opportunity to travel there and be part of those first 25 cases in humans. And that's exactly what is being done there, right? Created a colotomy. Now, very easy or relatively easy, we're going to deploy the autolock and then create a colotomy. This is with the older version in which you had to kind of like take the instrument out and use two separate instruments. Now, the same device that deploys the ring is going to deploy the magnet. You can see there now how we are bringing the rings and then we're going to center them. It's very important to have those 4 sutures like a parachute in the middle of the ring. Same procedure, same process. And just going to advance here a little bit. Bring them together. This is one of the operations, I believe, when the assistant is probably as important or sometimes even more important than the surgeon. If you're doing this laparoscopically, inspection all around, we do not see any of the flanges of the autolock, and then we remove the sutures, making sure we brace them down, the bowel, so we do not displace that. And as time goes by, the anastomosis becomes stronger. This is one done here in Orlando very recently, patient with an extended right hemicolectomy. We're doing right now the first FDA approved trial here in the United States, a total of 20 patients. We're almost halfway through. And you can see in this case, actually, I did not even have a bedside assist. I was doing this on my own at the console. I created both the colotomy and the enterotomy. And right after that, I scrubbed myself and I asked the resident, first day working with the resident, to just hold the robot there and mobilize things as I asked him. So this is me now deploying that after I set up both parts of the bowel, deploy the ring. This is in the left upper quadrant. This patient had extended right hemicolectomy. And intracorporeal anastomosis with this orientation could have been quite challenging. Probably would have needed to redock or put an extra port and use just a laparoscopic bedside instrument. Now the resident is again holding the bowel here for me, dilated with a titanium grasper. Deploy the ring. And then we'll deploy that. Trying to get the proper orientation here. you can see towards the right of the screen how close my trocar is, because it was right at the left upper quadrant. It was very, very challenging. And I believe this anastomosis with a stapler would have been incredibly difficult to construct. I'm just trying to align properly there. But once I have the right angle, it's so easy. Boom, gets together, let it go. Try to avoid the metallic parts of the robot so it does not get stuck to the magnet, but should be able to inspect nicely and then remove bracing with the robot since it is ceramic on the outside, and remove the sutures, no problem. This is that patient on day 7. See exactly what I was talking about. The magnets are on the left upper quadrant. It was an extended right hemicolectomy. Challenging to put a stapler in that orientation, but we would have done it. This is a different patient on a right hemicolectomy. You can also see the ring, you can see the autolock there, probably already moved and displaced. This is something that has been spoken before about the biology of the healing, and it's just pure collagen. What you see in those anastomosis, there is not such a tremendous inflammatory response as you can see on staplers and sutures. And this is basically the two type of magnets, the flexagon and the megagon, different diameters, 25 versus 28, different forces of attraction. And there is also, as demonstrated before, different ways to deploy, including an endoscopic device and something that is being more recently tested, which is this transrectal device, which is something very relevant for colorectal surgeons, considering that colorectal anastomosis are probably the most feared in our field. But there is some help coming in that way. You can see here a combination of the regular flexagon with flexagon. This is at a distance of 4 millimeters. This is the force that is exerted, 0.76 pounds. If you combine the flexagon and the megagon, it's an increase of almost 60%, 1.2 pounds. And then the two big guys, 2 pounds, 160% increase in the force at that distance of 4 centimeters. I do believe that for the colorectal, for the rectum, the megagon is going to be really what's going to make a difference. This is the still a prototype, the Nexus. We were in Boston doing some PIC lab. You can see the difference between that kind of anastomosis made with this the magnetic device versus what you see on the right side with the staples, how different they look. In any case, all the pigs survived the time they were required to survive. This was after 7 days when they were sacrificed. And I believe this is probably one of the most important aspects of this in colorectal surgery, and is the ability to enable intracorporeal anastomosis. A lot of people don't realize how important this is, but most of the colorectal anastomosis, ileocolic anastomosis in right hemicolectomies in the world actually perform extracorporeally. Many of those are done by general surgeons who do a variety of cases and do not do intracorporeal anastomosis for various reasons, because they lack the time, the training, the experience, you name it. But extracorporeal anastomosis have all sort of complications in the long term, and the cost is enormous through the years. The creation of extracorporeal anastomosis for various reasons. This is a survey from Australian general surgeons. These are all the reasons why they don't do it. We already talked about those, but it is a significant advantage of using this type of technology. This is the data from those first 25 cases in humans performed in India. This paper has been accepted on DCR and is currently going through production, but fundamentally 25 cases, no leaks, no complications. There were like patients that developed an ileus, or patient that had a headache. All of them were like Clavien-Dindo 1. There was not a single serious complications or readmissions. The details are coming very soon. 95%, meaning 24 patients had eliminated the device. By day 30, one patient needed removed on day 60, not symptoms, but it was identified on the X-ray, so it needed to be removed. Thank you very much for the opportunity, and I'm excited to what's coming in colorectal with this technology.
Thank you. That was a great talk, and very exciting, certainly for the field of colorectal surgery. Our last speaker is not only needs no introduction, but is going to be introduced by Dr. Eric Wilson.
Thanks, Christine. Yes, it's a great pleasure to introduce my long-term friend and Professor Dr. Manuel Galvo Neto. Manuel is the Director of Bariatric Research at Orlando Health, Weight Loss and Bariatric Surgery Institute, and he's a bariatric endoscopist there, as also is the Scientific Director of ERCAT India and the Director of Bariatric Endoscopy in India. Thank you, Manuel. We're here to talk about the endoscopic approaches across the whole spectrum of the gut. So thank you, Manuel.
Thank you, Eric. We have my presentation recorded, so Thiago can run it now. Greetings, Manuel Galvo Neto. Today we're going to talk with you about the magnets and the interface with endoscopy. So again, thank you very much for the invitation for this webinar. I think it's a very important one about the magnetic surgery. Where I'm coming from, I'm broadcasting from Orlando Health. You have Dr. Andrea Teixeira with you, also Dr. Mohit Bandari. You have that work with him in India and ERCAT India, and Dr. Elias Ortiz in Mexico. Those are my conflicts of interest. For you to judge if this presentation is going to be commercial or not. So magnets, for sure, we're going to talk about what you're seeing today in this webinar with the self-forming magnet. And possibly you have already seen that the idea of compression, anastomosis by compression, is not new, but now it's time. It's time that the magnets, as you can see in front of you, compare the pictures left and right, magnets and without, and surgery with suture and staple. That's a difference on that you already get the explanation for that from the previous presentation. So in the beginning, endoscopy, it was king. So in a small bowel, the very first trial that we are aware of, and with Dr. Thompson and Dr. Evsey Machika in Czech Republic. So it's endoscopy, past the triangle, 70 centimeter away of that triangle, then colonoscopy intubate the ileum, 40 centimeters, face each other, X-ray, as you can see here in the smaller picture, a dropping zone. So open up the magnets, they will self-form, then you align them, let them go, they will couple, and in 7 to 40 days, they will form an anastomosis. And this case is the jejunal ileum, and those kind of anastomosis is the basis of the modern metabolic surgery as we know, with together interventions on the stomach. So this is the paper that was published, and then you can see here those is 1 year paper, and then those patients were followed for 3 years and 18%, around 18% total body weight loss with a drop of 1.8% of H1C on the diabetic patients on that. So very good results. And based on that, we went, and now start getting involved on that. We went to Argentina, to the German Hospital of Buenos Aires with Dr. Rudolf Baron. And you see here this very happy crew, and cases were being done, but at the cost of having the most experienced endoscopists involved in a 3 to 4 hour procedure. So it was hard to do that. We question the reproducibility of this. So we get back to the lab, and on the lab you see Dr. Baron that a hybrid procedure was developed. And with this hybrid procedure, endoscopy is not king anymore. We are secondary, we are ancillary to the anastomosis. And you can see here the paper published that backing a little step down on the hybrid way. So laparoscope, Laparoscopy, 300 centimeters away of the ileocecal valve, small enterotomy, cannula, and open up the magnet. Then close it. Then by endoscopy, duodenum, anterior wall, open up a magnet, as you can see here. And then it's just a matter of covering the duodenal magnet with the Bowel magnet, so the anastomosis they are formed, and you can see here the end results 2 months, 3 months after. Beautiful anastomosis. So that's the procedure that was designed from that. On the sequence, went to Barcelona, Dr. Roman Turó in the Technon clinic, and those patients for this trial, they were patients with sleeve gastrectomy that failed to lose enough weight, or they had a recurrence of the weight that they had lost. So the duodenal was planned, and you can see here these pictures of the original work, and you have the publication of 9-month results. That is 17% total body weight loss, and the patients were followed for 1 year, and it's 19.4% total body weight loss with good metabolic control. That's a very remarkable weight loss for a revisional sleeve gastrectomy. So on the evolution, in India, we test the new magnet. You can see it's a little bit different, a little thicker, more well designed, and you can see here that we are in the duodenum, so we are exposing the magnet form in front of the cap, a small weak magnet just to put them together. And when it's done, you can see here right now, we're gonna turn off the light of the endoscope, and we will guide ourselves with the light of the laparoscope. And when it is ready, when the surgeon, in this case Dr. Mohit Bhandari, thinks that is enough, that's good enough, we apply suction on this modifier so it become a target. And you can see here that Dr. Mohit Bhandari already have implanted the ilium magnet, and he's manipulating that with titanium graspers specifically designed for that to not get attached to the magnet. So he was just doing and covering. So that's it. A procedure that comes from 4 hours, now is 15-20 minutes. And the beauty of this is the end result. And you're going to see here we are inside the duodenum, getting back near the pylorus. And you can see here the beautiful anastomosis with the clear alimentary limb and biliopancreatic limb. And even doing NBI, you're going to see that's no sign of inflammation. So it's a very well-formed anastomosis for that. So in the sequence, still using endoscopy. So what you see here is a paper from Canada, a multicentric paper from Canada that was fresh sleeve gastrectomy with duodenal-iliomagnetic anastomosis, and the results are surgical. 31% total body weight loss with an incredible drop on A1C and the drop of the anti-diabetic medications as well. So we well. From that, evolved to immediate anastomosis, where endoscopy still have some part of that. And this is a major advancement, the addition of the autolock that will keep it open. And you can see also the whole equipment get improvement. So you can see on the right side, it looks like a staple. Left side, we have a better delivery system for endoscopy. And then we were in India, and for sure, led by Dr. Mohit Bhandari, we published our results on that direction. And at the same time, in US, we got it immediate anastomosis for small bowel from the FLOWS trial. There's an FDA trial in that direction. So see here, Dr. Mohit Bhandari duodenal-iliac anastomosis. There's a risky anastomosis in a SATI. And you can see here, the autolock deployed, the magnets, and they're there, just there. And you have here on the cartoon how the immediate flow is assessed on that direction. And for sure, we're going to have endoscopy here as an ancillary. We're going to check the anastomosis. We're going to test the anastomosis with the injection of inflating CO2. So it's just about now. So we're doing the endoscopy. And we can inspect the whole sleeve gastrectomy and also get into the duodenum. We can inspect the anastomosis itself and seen by outside as we inflate with CO2 if there are no leak and this is safe anastomosis. So 3 months after, just take a look of how beautiful is this anastomosis. That magnets already passed, everything is there. That's just a very thin line that is like nothing, no inflammation, no foreign body. And you see the staple here is because it was across the staple line. So it's really, really, really remarkable. So it's got FDA approved, and you can see here our first commercial cases. Now we have about more than 30 cases done, commercial cases since the very first one in April 13 of this year for small bowel. So the research continues, and now in the stomach, and endoscopy can play a little role that we can deliver the magnet inside the pouch, and then after the magnet is implanted on the bowel side, as you can see here, we have a slight modification. There's a polypectomy snare. We can grab the suture of the other magnet and we can align them better for that. And we have done this way. Also, it doesn't necessarily need endoscopy to do that. It can be laparoscopic, but it's a modification that sometimes can be useful. So you can see here, there's a Roux-en-Y gastric bypass. You can clearly see throughout the autologs from the stomach into the bowel. We can also test that direction. So this is an OAGB, and you can see that you can put the magnet in any place, in anterior wall, posterior wall, depending on what the surgeon requests. Again, we can see through the autologs, and you're going to have the opportunity to see we are checking the anastomosis with inflating by CO2. So that is a beautiful form of anastomosis. This is to show you a bipartition. And the anastomosis, again, well formed, and let's check by endoscopy to see what we have, and you can clearly see here that they are. So we use the endoscopy to check them. You see in that round, now it's much more than that, but at that time, 67 anastomosis, immediate delay, even getting ESG plus magnetic anastomosis in the direction with no complications related to magnetic anastomosis itself. So you can see here the safety, at least in this trial, with no leaks, bleeds, and structure, and even the Amplify series with all the things together that we have on the small bowel. 117 American patients, not just to say that we were abroad, 87 diabetic, with 28 cancer patients. So, and how about colon? So in colon, again, endoscopy is ancillary. This is just we can use to check, as you can see here. In that case, it was a left colon, and we can lower anterior section, and we could check, and we can inflate, we can test that. You can see in that round in India, we did 10 cases with success of that. So now to tell you that we are doing Dr. Antonio Caicedo is performing the US trial. You can see here one anastomosis of his trial, beautiful one, but it's for right colon and transverse right colon. That endoscopy, we don't have access to that. So that briefly is what we wanted to talk to you about it in what is the role of endoscopy in magnetizing this year of 2026. So thank you very much.
Thank you so much, Manuel. All these talks are terrific. Unfortunately, we won't have much time for discussion or questions, but I think all the speakers have done an incredible job educating us on this exciting new cutting edge technology that is only going to increase in exposure, in experience, and in popularity. A lot of people are thinking, why is Chris Renfielding chairing this? And it's because I've embraced this. We've started performing magnetic anastomoses with GI windows a couple of months ago, and we're very pleased. And for that, I'd like to thank all of our speakers, my co-directors, my co-chairs, and of course, the IBC for putting together this really great webinar. And with that, I'd like to thank all of the entire audience for spending time with us. And as I said, with that, I'll pass it on to Tom Rogolo.
We would like to thank the faculty for taking part in the webinar today. and would like to share this sponsor promotional video.